The posterior shoulder contains three critical clinical portals through which neurovascular structures pass to transition from the axilla to the posterior arm and scapular regions. These spaces are defined by the intersection of the long head of the triceps brachii muscle with the teres major, teres minor, and humerus. The most superior and lateral of these is the quadrangular space, which is bordered superiorly by the lower margin of the teres minor muscle and the subscapularis anteriorly. Its inferior boundary is the upper margin of the teres major muscle, while the medial border is formed by the long head of the triceps brachii, and the lateral border is the surgical neck of the humerus. This space is clinically vital because it transmits the axillary nerve and the posterior circumflex humeral artery. Compression within this space, known as quadrangular space syndrome, typically results from hypertrophy of the bordering muscles or trauma, such as an inferior shoulder dislocation or a fracture of the surgical neck of the humerus. Patients present with weakness in shoulder abduction beyond 15 degrees due to deltoid involvement and impaired external rotation from teres minor paralysis. Sensory loss occurs over the lateral shoulder in the regimental badge area. Medial to this is the triangular space bordered superiorly by the teres minor muscle, inferiorly by the teres major, and laterally by the long head of the triceps brachii. Unlike the quadrangular space, the triangular space does not contain a major nerve, but serves as the passage for the circumflex scapular artery, which provides the crucial collateral circulation to the scapula by anastomosing with the suprascapular and dorsal-scapular arteries. This anastomosis is vital during ligation of the axillary artery between the thyrocervical trunk and the subscapular artery. Inferior to the quadrangular space lies the triangular interval, which is an anatomical gateway located between the lateral and long heads of the triceps brachii and the shaft of the humerus. Its superior border is the teres major muscle. This interval is the conduit for the radial nerve and the profunda brachii artery as they travel from the axillaria to the spiral groove of the humerus. Injury at this level often follows midshaft humeral fractures, resulting in radial nerve palsy. This manifests as wrist drop due to the loss of the extensors of the wrist and fingers, along with sensory loss on the posterior forearm and the dorsal aspect of the first 3.5 digits. High-yield correlations include the fact that the long head of the triceps is the only head that crosses the glenohumeral joint and acts as a divider between these spaces. Understanding these boundaries is essential for diagnosing peripheral nerve entrapments and predicting the vascular consequences of proximal humeral trauma in a clinical setting.